Emma's already told you all about our plans for next year, and probably like many of you, you've been scratching your heads thinking, I've never heard of the WHO Essential Medicines list. And some of you may have even gone onto the site and actually looked at it and thinking, wow, what do I do with this? So I'm just going to spend the next 20 minutes talking about what currently is in the WHO Essential Medicines list, who it's aimed at, and then also how the Government Advisory Committee on Antimicrobial Prescribing Resistance and Healthcare-Acquired Infection, or APRI as it's known for short, have adapted it to meet the current English healthcare-acquired infection and AMR sort of priorities by adapting it sort of through there, and I'll show you a few tools. So, what is the WHO Essential sort of Medicines list? Well, it applies to the whole world, so it's not just the developed world on here, and it's basically a list of minimum medicine needs for basic healthcare systems, and it lists the most efficacious, safe, and cost-effective. And cost-effective is really important, and it's for priority conditions, because in low and middle-income countries, they don't have the amount of money to spend on healthcare that we do elsewhere, and it might be apparent in some of the lists. It looks at priority conditions and they select based on sort of current and estimated future public health relevance and the potential for safe and cost-effective treatment. And there are two lists. There's one for adults and there's one for children. And there's a core list and a complementary list on there. And they're actually updated every 2 years, and they get experts in their area from around the world to update them. The complementary list for priority diseases is actually works on sort of specialised diagnostic and areas that actually have monitoring facilities, or they actually have specialised medical care, or where specialist training is actually needed. So let's focus on the antibiotic list. So we're on our 20th adult list and our 6th children's list. And they've done an overhaul of antibacterial lists outside of disease-specific subsections of tuberculosis, HIV, hepatitis, malaria. And these are kept up to date every 2 years because it's quite a rapidly sort of changing field. What they did last year to try and reflect some of the global challenge we've got in antimicrobial resistance and very much give guidance to some of the countries that don't have robust antimicrobial stewardship programs is try to separate out all of the antibacterials into antibiotics which you should be really using first or sort of second line. Those where you really have to try and sort of use them because there aren't many sort of options because of resistance out there, and those we should be trying to reserve. And so we've come up with these three terms: access, watch, and reserve. So access are first and second choice antibiotics for empiric treatments for most of the common infection syndromes. Watch are those where there is higher resistance potential and whose use as first and second line choices should be limited to a small number of syndromes or patient groups. And finally, the reserve ones, which are our last resort antibiotic treatment sort of options. So I'll take you through the three groups. So the first group is the ones they're trying to encourage more use of around the world. And you'll see on the lists sort of on here that there are actually some antibiotics in the access group which in the UK we're actually trying to reduce the use of. And these would include things like amoxicillin and clavulanic acid and clindamycin, which we've sort of put on our 4Cs list that we want to try and reduce. But you will see most of them are fairly sort of narrow spectrum. And then on the right-hand side, you can see there are some antibiotics on there which they've actually also put in the watch group. And the reason they put them in the watch group is there are some parts of the world where they have such high levels of resistance that they realise they're going to have to use drugs such as vancomycin, meropenem, piperacillin, tazobactam because of resistance. So they've straddled a few, and I think that makes it a bit confusing. The watch group is antibiotic classes are generally thought to have either higher toxicities or we certainly know there is increasing resistance potential. And again, the reason they're put in the sort of the watch group is to try and help countries develop tools for stewardship. So they're able to try and focus on this group to say, actually, keep a really close eye on what you're doing with these and try and make sure they're not increases. And not surprisingly in this, we see things such as some of the anti-pseudomonal and beta-lactamase combinations, such as piperacillin tazobactam, carbapenems, third-generation cephalosporins on there, which you'll see things like ceftazidime, the glycopeptides, macrolides, and sort of quinolones sort of in there. And then the final group is what they call the reserve group. And these include new antibiotics. And even though the pipeline for new antibiotics is a bit thin at the moment, we're not seeing a number coming sort of through, they're being put in there. And then finally, some of the last line resort sort of options. And these should really be protected and prioritised as key targets for countries in their antimicrobial stewardship programs to try and minimise the use of these in a very efficient way. And you'll see included in there, somewhat probably surprisingly, is things like aztreonam. So aztreonam they often use for some of the most carbapenem-resistant infections, some of the NDM type of bugs out there. And so that's why it's sort of on the list. Fourth and fifth generation cephalosporins, daptomycin, IV fosfomycin, the oxazolidinones, such as linezolid, tedezolid, sort of coming through. And you might think, why that's sort of going on? But actually, if you've got multi-drug resistant TB, we often use as a treatment, so that's why it's included. And then the polymyxins, which of course Callistin's had a lot of publicity about using it in sort of the animal food production sector and things like tigecycline. But there are also a number of other groups that weren't sort of listed in there. So all TB drugs, many of the first and second generation cephalosporins, other beta-lactams that are used in some countries but not globally, things like temocillin, not all the aminoglycosides were included, and they only mentioned some of the more common tetracyclines. Some of the skin, the acne-related tetracyclines were missing, and they didn't really focus on some of the older fluoroquinolones. But one of the really key areas that were missing on there was the UTI agents. They were just missed out sort of totally. So trimethoprim, oral fosfomycin, pivmecillinam, methenamine, things like that. And then there were a few sort of miscellaneous ones which weren't on the list. So what Public Health England have done, have actually applied the current list to English antibiotic usage. And I'll just show you a couple of slides sort of on here. So this is English primary care antibiotic usage. And you'll see over time the access group has actually been decreasing, which is good. Well, actually, which is not good. And part of the reason for that is because included in there, as I said before, are things like coamoxiclav and clindamycin. And we've been making real efforts to try and reduce some of those. So it didn't really fit sort of quite so well in there. And these are box whisker plots on here. We're showing the interquartile ranges on here. And the one on the left-hand side is showing there's still an enormous variation between the CCGs of what actually sits within the access sort of list. Okay, when we look at English sort of secondary care sort of on there, the access group as it exists is staying roughly sort of about the sort of the same. It probably doesn't come out very well, but the second line down on the left-hand side shows there's this sort of slow sort of increase in the access and watch type of list, which contains things like meropenem in there and piperacillin tazobactam, so it had been increasing. And again, same type of thing with variation, and you'll see a huge variation in that access list. And so we've seen some data before from Emma showing what was in the other groups apart from sort of access, and you can see again enormous sort of variation in the ones that we want to try and use sort of less of per hospital. And when they add everything up, and I'll just focus on the very top line, that it's under 2% are in the reserve group, 5% were in the watch group, and 21% were in the watch and access group based upon the WHO sort of list on there. So we've seen the list. but actually the list as it stands at the moment really doesn't reflect what we've been trying to do, and I think we've been making huge strides on within the UK. And we've really had to sort of stand back and say, what do we need to do to try and sign up to the WHO initiative on antimicrobial resistance and using better choice of antibiotics, but try and adapt it to reflect the current UK initiatives on healthcare-acquired infections, where we have been successfully driving down Clostridium difficile infection, things like that. So, what did we do? So, the first thing we did was actually try to get rid of the access watch category, because it didn't make any sense to actually have things straddling sort of two camps. It really sort of muddied the water. And so the access watch list was combined into the watch list on there. And so we had the macrolides moving in there, some of the fluoroquinolones, so ciprofloxacin, cefixime, vancomycin in there. And then our current 4C antibiotics, so Comox, clindamycin, cephalosporins, and all the fluoroquinolones will move from access into watch. And then finally, because we've actually had a real driver on trying to reduce the amount of carbapenems that we've got, because carbapenem-resistant organisms aren't a big problem currently in the UK, we've moved them into the reserve list. And then we looked at the other list, and I mentioned already that some of the UTI treatments were missing. So we moved trimethoprim, tetracycline, fosfomycin orally, pipimicilinam into the access list, and also fusidate. And then there were some others from the other that moved into the watch list. So you can see some of the 4C remaining agents such as cephalosporins, fluoroquinolones, and then things like the acne tetracyclines, where we're really trying to minimize some of the use of those outside of when they're not sort of routinely sort of needed. And then moving some of the unlicensed medicines, so pristinamycin. If any of you work in France, you'll see it's an oral agent that has MRSA cover on there. And then some of the specialist aminoglycosides we use in CF, such as tobramycin. So, with the new lists that we've got on here of access, reserve, and watch, PHE have then plotted how we've actually been doing sort of over time against the use sort of in access. And what you'll see is, from 2011, where we have sort of the data moving onwards, you can see there's been a slow decline in actually our percentage uses of those in the access list, which is probably not what we want to see if we're to try and sign up to what the WHO is trying to sort of do sort of on there. And then we've had sort of within the watch list fairly sort of steady on there. So how do we apply this in sort of practice with England? Well, primary care already focus on reducing most of the antibiotics in the watch group, so the cephalosporins, fluoroquinolones, Comox, clav, and they've really been trying to get sort of the figures to below 10% of all antibacterial prescription items, and certainly now it's about 8.9%, and that's been really successful. So primary care are just going to carry on doing what they're doing. In hospitals, however, we know that the sequence to do with antimicrobial resistance and then moving into serious infections is reduced, focused on reducing the total carbapenems and piptazo. That's partly because we'd overused them, certainly the carbapenems and piptazo, and we've driven resistance of piperacillin back down. Now, the shortage that came along back last April really forced all organisations to change nearly all of their antibiotic guidelines. And despite some more piperacillin tazobactam actually coming back into the market now, though at a much higher price, quite a few organisations haven't changed back. And so this is where the proposals come to replace the piptazo-sequin element with an increasing portion of antibiotics in the access group by either 3% or to try and move to 55%. So, what's in the lists? And I'm sure I can probably hear a whole load of shutters taking lots of pictures here. And unfortunately, it doesn't appear to have fitted on very well. But you can see the access ones are all the sort of the narrow spectrum type of agents. Those are in the watch, which tend to be our sort of 4C sort of antibiotics sort of on here, and then the ones in the reserve list. I'm not sure if you can amend that slide so it actually fits on the page, can you? As it did when I sent it to you. There we go. So there's the full list. And so you can see the ones that we're really trying to do, some of the azathioprine and the newer cephalosporins that are coming, colistin, daptomycin, carbapenems, IV fosfamicid, linezolid, tenezolid, telavancin, because we quite often have a resistant with some of the vancomycin-resistant enterococci that can be a problem, and tigecycline. And you can see the access list is what we want you to try and sort of focus on. So, are there any tools to help you? So, as Emma's already said out there, one of the companies who we use for the model hospital dashboard is RX Info, and data gets put into there. And to try and help us, we've actually got them to design some tools for us already, so we don't have to try and do lots of maths. It's there ready to use. And they've done 3 of reports for us to separate them out into the 3 elements in there. And so they will actually, and you'll find them, because we've not had the sign-off from NHS England yet, we've called them RMOC, which stands for the Regional Medicine Optimisation Committees, just so we can report to them. But we will probably rename them once we've got formal sign-off. And so I'll just show you some data from Yorkshire and Humber, and that's where I do half of my job as an antimicrobial pharmacist. And so on the left-hand side, it shows the split on there, and the mean and the access group is 48% in Yorkshire, but you can see there's a wide range of 32 to 63%. But on the right-hand side, we've actually got a number of trusts who are already over the 55%, and they're the ones who've tried really hard to use lots of narrow spectrum sort of agents. So you've got people out there such as York, Harrogate, Airedale, who can actually say, well, I've ticked that box already. And then you've got other trusts at the left-hand side, and I won't name them, but they've actually probably got a lot more work to do because they're still predominantly using lots and lots of coamoxiclav, probably still lots of piperacillin tazobactam. And we're going to work as a network on how we can support them moving in the right direction. Now, one of the questions that will probably come from the audience is, yes, but I'm special because I work in a big teaching hospital like I do in Leeds, and I do transplantation, I have lots of oncology, hematology patients, so I'm bound to use lots more. And so if you look at the teaching hospitals in the sort of the group, and the access group is the orange one, it's 45% of their use is in there. Medium-sized trusts, 49, large trusts, 46, small trusts, 51, which might reflect where they are. And then the difficult groups are really some of the specialist trusts out there who are, I think, are a challenge for a lot of the things. And so that's why there's the 2 options in there. So, in summary, the WHO Essential Medicines List is basically a list of medicines needed for the basic medical care of most of the sort of the common conditions. And they're based very much around efficacy, safety and cost effectiveness. We had a revision in 2017 to separate out between access, watch and reserve, and it's known as the AWARE list as you throw them all together. Access is first and second line choices for empiric therapy. Watch has got a higher antimicrobial resistance or safety potential, toxicity potential, and reserve are really for last line antibiotics. And certainly within England, APRI have revised these to apply to England. And huge thanks to Dr. Susan Hopkins and Dr. Emma Budd from Public Health England, because they pulled most of this sort of data together. Thank you very much.